And we look forward to our last speaker, Dr. MAHIPAL SACHDEV, who needs no introduction, who's our immediate past president and also the chairman and managing director of the entire Center for Sight Group of Hospitals, an amazing cataract and refractive surgeon. And he's going to take us on a very challenging course, Unplanned Smile Challenges.
Thank you very much, Dr. Chitra, and I'll be going through a couple of videos. These are unplanned smile challenges that it is. Everyone has gone through the smile procedure. There's just a circle scan. I think Shreyas showed it, but for enhancement, you just need to do a circle scan. You just still don't have the commercially available smile on smile. So either you can do a surface ablation or you can do a circle scan where the cap is converted into a flap. So it's the only thing which I have is that you have to pay for these treatments. So you're not charging the patient and you pay for a treatment for that. That's the only thing. But apart from that, it's a simple procedure, and you can see that you get this donut kind of a situation, and you can just lift the flap that has been created. And mind you, this is a fresh cut, so the chances of epithelial ingrowth are not there. So it is not a relifting of a flap, but it's a fresh cut, and then you take the patient to the laser and do that. Suction loss, because there is a larger duration, what it is, the newer one, the time is reduced by about 10 seconds, but as things stand, we have about 23-24 seconds, and the suction is not very hard, so you can lose it. I don't know if anybody has covered this or not, but if you are during a lenticule cut right from the start, if you lose suction within 10% of the first cut, it goes back to 0. That means you restart. During lenticule cut, if you have greater than 10% of the lenticule having been cut and you have not completed the posterior cut, then you have to actually convert it into a flap. And during lenticule side cut, you can repeat for the side cut, and during cap cut, you can repeat from the cut. So I'll just show you all these different. So this is suction loss, sorry. This is suction loss at the time of posterior lenticule cut. So you can see that this is the posterior lenticule cut and you have a suction loss here. So what we have to do is at the same time we can make it into a flap, and then you go ahead and do an excimer laser on this particular case. Now this is suction loss. This is during the anterior lenticule cut. So you can see this is the posterior lenticule cut that is happening. So you go ahead. You'll have the side cut which is coming on. You can see that there is some fluid starting to come, and then you have the anterior and you can see this fluid. So ideally you can stop here, but in this case we lost the suction, so I would, because there is so much of ballooning, I would stop myself. You go ahead with the same patient interface, the machine takes you there and you redock, and then you can restart. So you can see that this is restarting of the anterior lenticule cut, and you can go ahead and then, though it is slightly decentered, you can see it is slightly decentered, but this is the side cut that you are having. And in this particular case there is absolutely no issue because it goes in the same plane, and you can go ahead and remove the lenticule, as you can see in this particular case. Now this is a suction loss during the side cut, as Shreyas was showing. So in but this particular case, I'll just go forward. You can see this is the you're tending to have this fluid coming in. So this is at this particular time there is a problem that you have in this particular case. So this is the side cut has not been completed, so we make it into a flap. This is the entry cut where you have at that particular time. I'll just go forwards. You can see in this particular case we are just able to do the entry cut. So this was just before the entry cut that you have, so you can make the entry cut again. I'll just go back, so you can see this is where you are having the suction loss. You see, so it was just before the entry cut and we went ahead and just did the entry cut. This is an eyelash that came in the center. So I have shown this for intralace. This is for smile. Again, you get an uncut area. So please do not let the femto fire when you have debris, and especially a cilia. So this is going to leave an uncut area which is going to cause a problem. This is remnants of lenticule, which you can see. This has been overhyped, I say. I don't think once you are experienced enough you have any of these lenticules remaining, and if your cuts are not proper, so what you can do in these cases is that you could stain it with tricont, you can put air, you can even use any dye, and you can see that. Another thing is that you can use the slit lamp as you are seeing in this particular case and remove the lenticule fragments that is there, but they need to be removed. This is to just show a microscopic integrated IOCT. This is not smile actually, this is the ELITA system of J&J that we are working on, and you can see in this particular case we have marked the centration. So here the MIOCT actually guides you onto the plane. So can you see this? This is going into the posterior plane. Can you see this? It's clearly shown on the MIOCT that you have gone into the posterior plane, and therefore you should have gone into the anterior plane. So you again go and take this out, and you will see here in this particular case this is the anterior onto the anterior. So the OCT can be a useful guide which is there. This is just to show you a very rare complication of having epithelial ingrowth or nests, actually not an ingrowth, but you have nests. So you will have to open it up and clean it up and maybe put mitomycin C and do that. This Shreyas Gitansha et al, they have reported this is unilateral corneal, sorry, this is our, so this is just mix up. We have actually reported unilateral corneal ectasia following smile, and this is unilateral sterile infiltrate which responded to steroids that has been reported. This is one single case where the other eye in unilateral corneal ectasia post smile. So you have to follow the same mandates that you follow for LASIK as you follow for smile. So smile may be potentially better as regards the biomechanical strength, but do not overstep the caution. And in such borderline cases, we do smile extra, and smile extra tends to work much better than LASIK extra which is there. Thank you very much for your kind attention.
Thank you. Just one last simple question. In
Yeah.
case of suction loss in smile, would you prefer to wait for the OBL to clear, or would you proceed immediately? And the second question is, would anybody in the panel would think of doing PRK in the same sitting, or would you prefer to post it for a different day?
So first of all, majority of the cases I won't do a PRK because you are able to either make it into a flap or you can redo it, and I don't wait for the OBL to clear at all. I just, I don't know.
I think the OBL gives you a guideline
Better
for docking,
slaying.
but
Yes.
then the patient fixation is not good. So what you
Yes.
can do is you just massage the center, so the OBL just clears in the center and the patient is able to see the green fixation light,
Yeah.
and then you can dock, and the edge of the OBL kind of acts as a guideline where you can kind of
Very
center.
rarely we're caught in a situation, would you do PRK on the same sitting?
No, I've never
What
done it, I don't
situation
know.
would that be? I don't know, but basically if you have to and the patient has to go somewhere, but ideally I would wait for the patient if I can't do the procedure at the same time. PRK patients are really not very happy with that, but if you have to, you have
And
to.
if you have a lenticule cut and you do PRK, the incidence of haze is more. So I
Yes.
don't really like doing.
Okay. Thank you very much to all my core instructors and my dear audience. I do hope you all gained something from this variety of talks.